I used the John Hopkins Appendix H synthesis and recommendations tool. I had 3 studies that were level 1. This would be experimental studies, RCTs, systematic reviews of RCTs with or without a meta-analysis. They were good quality, which means they had reasonably consistent results, sufficient sample size for the study design, some control, and a reasonably consistent recommendation based on fairly comprehensive literature review that includes some reference to scientific evidence. One of the studies did not identify a reduction in the rate of surgical site infections, but there was a confirmed activity in reducing colonized bacteria on the skin. The second study supports to show that surgical showering with chlorhexidine is effective for reducing bacterial burden, but the effect on surgical site infections was inconclusive. The third one, preoperative use of chlorhexidine could reduce the incidences of infection among moderate and high-risk category patients, and the antibiosis effect of chlorhexidine were most obvious in the high-risk category patients. The other study was a level 4, which was a cohort study. It was conducted in a hospital, and it was a good quality study. It was reasonably thorough and appropriate, and had reasonably consistent results, sufficient number of a well-designed study, and evaluation of strengths and limitations of included studies with fairly definitive conclusions. The conclusion for this study was there was an overall reduction of surgical site infections in the group that received chlorhexidine bath before surgery. The group was comparable in every aspect except that the bath group was older, and this bath group also experienced emergent surgery less frequently. The study also found that the cost of having a chlorhexidine bath was allotted a total financial burden of $7 per patient. For the study, it would be reasonable to predict that any additional morbidities or length of stay associated with a surgical site infection would exceed $7.